Welcome back to the deep dive. All right, let's jump right in. Today, we're tackling a condition that, well, thankfully it's rare now, but it's still absolutely essential knowledge, especially if you're prepping for exams or, just want to understand some pretty complex medical stuff. We're diving deep into Reye syndrome.
That's right, and we're using a set of uh, really focused revision notes as our guide today. Think of it as the high-yield summary, all the key facts you really need on Reye syndrome distilled down.
Perfect. So the mission, as always, is to unpack these notes together. We'll pull out the absolute must-know info and try to make it stick for you. Consider this your fast track to getting your head around this condition. Let's get started.
Okay, so first things first, what is Reye syndrome fundamentally?
Well, the notes define it as a very rare but really severe condition. It primarily hits children and teenagers. And the two big problems it causes are sudden brain dysfunction, that's encephalopathy, and liver dysfunction.
Right, and here's the absolute key link, the thing that notes really hammer home. It nearly always follows a viral illness, and the child has taken aspirin. The underlying mechanism seems to be this cascade. You get the acute brain problems, this fatty change in the liver, and it's linked back to mitochondrial dysfunction. Problems with the cell's energy factories, basically.
So it's systemic, isn't it? Affecting the liver, kidneys, the brain, multiple organs. And you mentioned that strong link to aspirin. The notes also point out these Reye-like illnesses. They can look similar, but are often tied to underlying metabolic disorders, not the specific Reye's trigger.
Exactly. You've got the classic Reye's with the virus-aspirin connection, and then these mimics that you need to be aware of and rule out.
Okay, so for memory, the notes kind of frame it with a simple triad, right? Kids or teens, plus a recent viral infection, plus aspirin use. That equals big trouble for the brain and liver. That's the core concept to grasp.
That triad is definitely key for initial suspicion.
Yeah. Okay, so we know what it is and the key association. But why does it happen? What about the etiology, the cause, and the risk factors?
Well, the notes are pretty clear. The exact cause isn't fully understood. It's thought to be, a combination, probably some genetic vulnerability meeting certain environmental triggers. But the single biggest risk factor, without a doubt, is using aspirin or salicylate-containing meds during a viral illness in a child or teen.
That combination again. So it's specifically kids and teens, maybe with flu or chickenpox, given aspirin. That's the danger zone.
That's the perfect storm scenario, precisely.
Which brings us to pathophysiology. How does this actually play out inside the body? There's still some mystery, but what's the main idea?
The leading hypothesis, according to these notes, focuses on that virus plus aspirin combination leading to mitochondrial damage, particularly in the liver cells. This messes up energy production, metabolism, and that leads to the fatty liver changes and the brain swelling, the encephalopathy that we see.
Fascinating. Starts right down at the cellular level. Okay, let's shift from the micro to the macro. What do you actually see? The clinical features, the presentation?
Okay, so for older children, the classic story often starts after they seem to be getting over a virus, like a cold or the flu. Then suddenly, things take a sharp turn for the worse.
So they look like they're recovering and then it hits.
Exactly.
Yeah.
The first signs are usually this really persistent, severe vomiting. They get increasingly lethargic, tired, sleepy, and you see changes in their mental state. And it happens pretty fast.
How does it progress from there?
Well, the vomiting continues, maybe diarrhea too, especially in younger kids. They become listless, really lethargic. Their breathing might get rapid tachypnea. Then the neurological signs worsen, maybe confusion, becoming combative, then progressing to stupor. They might even have visual hallucinations. Pupils might react sluggishly. And the notes make an interesting point. Those really dramatic signs of raised intracranial pressure, like specific posturing, they might not be obvious right at the start, which can make it tricky.
Yeah, that is tricky. And in the worst cases?
Severe progression means seizures, deep coma, and sadly, it can be fatal.
And what about the liver? What do you see there?
You get evidence of liver damage, and often the liver itself is enlarged hepatomegaly. But here's a really crucial point the notes highlight. In typical Reye's, patients don't usually get jaundiced, that yellowing of the skin and eyes. The absence of jaundice is actually a key feature that helps distinguish it from other types of liver failure.
Okay, no jaundice. That's definitely a high-yield fact to remember. Now, you mentioned older children. How does it look different in infants? Because they can get it too, right?
Yes, and this is a really critical distinction. Infants often present quite differently. For one thing, vomiting is usually absent. Instead, you might see more respiratory symptoms like breathing problems. Low blood sugar hypoglycaemia is common. An enlarged liver, yes. And problems regulating temperature. And sometimes that preceding viral illness isn't as clear-cut or easy to pin down as in older kids.
Huh. So in an infant, sudden severe illness after maybe a virus, no vomiting, but maybe breathing issues or low sugar, you still have to think about Reye's.
Absolutely. That age difference in presentation is vital.
Right.
The notes kind of challenge you to think, what are the main differences between an infant and an older child presenting with Reye's? Focus on vomiting and how obvious the viral history is.
Got it. Infant. Often no vomiting, maybe respiratory, temp, sugar issues, older child. Classic vomiting, lethargy, mental changes after a clear virus. Okay, that helps. Let's talk epidemiology. How common is this, really?
Well, the big story here is how rare it is now. The incidence of Reye's syndrome absolutely plummeted from the 1980s onwards.
And that's directly because of the aspirin link awareness.
Overwhelmingly, yes. Public health messages about not giving aspirin to kids with viral fevers really worked. Increased awareness made a huge difference.
That's a massive public health success story. What are the numbers like now?
Very low. In the UK, for example, it's less than 1 case per million children per year. The classic age range is often cited as 5-14. But the notes say the peak incidence is actually around 2 years old. It can happen in the first year, but it's rare after 18.
So incredibly rare, but still possible. And recognizing it is key because the stakes are so high. Which leads us nicely into the differential diagnosis. How do you figure out if it is Reye's and not something else?
This is a major point in the notes. Reye's is largely a diagnosis of exclusion. You have to systematically rule out a whole host of other serious conditions that can cause similar symptoms, brain dysfunction, and liver problems.
Right, it's like detective work. What kind of conditions are on that list of differentials?
It's a long list, which shows why it's challenging. You're thinking about things like viral encephalitis, direct infection of the brain, acute liver failure from other causes, underlying metabolic disorders the child might have been born with, and importantly, intoxications or toxic ingestions. Given the aspirin link, salicylate poisoning and aspirin overdose is a really important one to consider, even though Reye's itself isn't strictly an overdose phenomenon.
Makes sense. What else?
Meningitis, other types of hepatitis. The notes even mention diabetes because severe vomiting can cause ketones in the urine, which might initially look like DKA. Hypoglycaemia itself is on the list.
Yeah.
You need to figure out if the low sugar is the cause of the symptoms or a consequence of the Reye's liver dysfunction.
Right, cause versus effect.
Anything else?
Head injury, acute kidney injury, other kinds of liver failure. In younger kids especially, things like intussusception, which is a bowel issue, severe sepsis, really bad gastroenteritis. Even SIDs, tragically, in the context of unexplained collapse. Wow, okay, that's a lot to rule out. So, memory tip. Reye's diagnosis, exclusion. Suspect brain, plus liver issues. But check off that whole list, infections, metabolic problems, toxins first.
Exactly. And the investigations are designed to help you do that, rule out the mimics while looking for clues pointing towards Reye's.
Okay, speaking of investigations, what tests do the notes say are typically done?
Labs are crucial. You're looking for signs of liver dysfunction, elevated liver enzymes, AST, ALT, a prolonged prothrombin time, meaning blood clotting is impaired, and really importantly, high ammonia levels.
High ammonia seems to pop up again and again.
It's a key marker, yeah, both for diagnosis and for prognosis later on. Low blood sugar, hypoglycemia is also common, especially in kids under 2. Standard bloods like UNE's urea and electrolytes to check kidney function, fluid balance, bicarbonate, magnesium, calcium, phosphate, serum osmolality, and definitely checking salicylate levels to rule out toxicity.
And urine tests.
Often show concentrated urine, high specific gravity, and ketones are found in about 80% of cases due to the vomiting and metabolic stress. You'd also do a full blood count and arterial blood gases.
What about imaging the brain?
Head CT or MRI is standard to look for brain swelling, edema, and also to rule out other structural problems like bleeds or strokes. Now, lumbar puncture, LP, to get spinal fluid. The notes say it might be needed to rule out infections like meningitis, but, and this is a bit of a nuance, they also say it's often contraindicated in typical Reye's.
Ah, right, because of the risk of brain swelling.
Yeah.
How do doctors handle that?
It really comes down to clinical judgment. If meningitis is strongly suspected, you might have to do it. But the risk of causing herniation if there is significant brain swelling is real. Often, the CT scan helps guide that decision. You have to weigh the risks.
Any other diagnostic tools mentioned?
A liver biopsy can be definitive. It shows characteristic fatty changes under the microscope. An EEG, measuring brain waves, can help assess how severe the encephalopathy is.
Okay, so pulling it all together, the formal diagnostic criteria basically say you need acute encephalopathy, plus evidence of liver dysfunction, and after a full workup, there's no other obvious cause.
That's it. Diagnosis by exclusion. The notes add that if an LP is done, the spinal fluid usually has few white cells. And a brain biopsy, if that were done, would show swelling, but not inflammation.
Right, consistent with a metabolic or toxic type injury, not infection. Okay, so you've diagnosed it or strongly suspect it. How is Reye's syndrome managed?
The notes are very direct here. Treatment is overwhelmingly supportive. There's no magic bullet cure for the underlying process. It's all about managing the symptoms, keeping the patient stable, and preventing complications.
So hospital admission, intensive care probably, is crucial.
Absolutely essential. Close monitoring in hospital, often in an ICU setting. And the number one rule, given everything we've said, avoid aspirin. That's non-negotiable.
Got it. What are the main goals of that supportive care?
Primarily, you're trying to correct the metabolic chaos, the low sugar, the high ammonia, electrolyte imbalances. You want to prevent anything else harming the brain. And you need to manage or prevent increased pressure inside the skull, the ICP. Early recognition and starting this supportive treatment quickly are absolutely vital for survival and minimizing long-term damage.
What are the immediate steps on admission?
Standard resuscitation, ABCs, airway, breathing, circulation. Keep the patient calm and the environment quiet. That helps with ICP. Check blood glucose immediately, especially if they're young or have altered consciousness. Treat low sugar straight away with IV glucose, often starting a continuous infusion.
Fixing hypoglycemia is top priority.
Yes. Other things include elevating the head of the bed, maybe 30-40 degrees if blood pressure is stable. Careful fluid management is key. You don't want to overload them and worsen brain swelling. Continuous monitoring of blood chemistry is needed.
And treating specific symptoms.
Controlling vomiting with antiemetics, like ondansetron, maybe antacids. Managing the high ammonia, there are drugs like sodium phenylacetate or sodium benzoate, or even dialysis in severe cases.
Right.
Controlling fever. Treating seizures if they happen, usually with anticonvulsants. And if there are clotting problems due to the liver dysfunction, giving vitamin K.
And the notes mention more severe cases go to specialist centers.
Yeah, typically stage 2 or worse really needs a tertiary pediatric intensive care unit. They have the expertise and equipment for things like directly monitoring intracranial pressure and providing more advanced organ support.
And there was that unusual liver transplant case mentioned.
Just briefly, yeah. A case report where severe, possibly Reye's-related liver failure was treated with a transplant. It's not standard care, but highlights that in extreme situations, very aggressive measures might be considered.
Okay, let's talk prognosis. What's the outlook for someone with Reye's?
It's really variable. It depends heavily on how severe the disease is, when they present, how quickly treatment starts, that kind of thing.
Is there good news?
Yes. The good news is that with earlier diagnosis and better intensive care, outcomes are much better than they used to be. The notes suggest that for patients presenting in the earlier stages, stage 1 or 2, maybe 65–75%, make a full recovery, which is encouraging.
That is good for milder cases, but what about the more severe end?
Well, severe cases, especially those that progress quickly to the higher stages, are still very dangerous. The overall mortality rate now is estimated around 20%, but for stage 5, the deepest coma stage, the notes quote, mortality as high as 85%. And even among survivors of severe Reye's, maybe 10–20% might have some lasting neurological problems, anything from mild learning issues to quite significant disability.
So tracking that staging is really critical for predicting outcome. Did the notes mention any specific lab results that suggest a worse prognosis?
Yes, ammonia level is a big one. Levels below 45 DORIS or DL are linked to a lower risk of neurological problems, maybe around 3%, but levels above 45 significantly increase that risk, maybe up to 11% or more. Other poor signs include progressing rapidly to stage 4, very high CPK enzyme levels, like more than 10 times normal, a specific AST to ALT ratio being less than 1, significant EEG slowing, high levels of certain fats in the blood, and low protein levels that don't respond to treatment.
That paints a clearer picture of who's most at risk for poor outcomes. And the notes circle back to prevention here too, right?
Absolutely. It's the most important message. Avoid aspirin in children and teens with fevers. Use alternatives like paracetamol or ibuprofen up to age 16 or 18. They also briefly touch on considering the flu and chickenpox vaccines for kids who have to be on long-term aspirin for other reasons, since those viruses are known triggers.
Right. So that simple message about aspirin was truly transformative. Okay, last bit, complications. What are the potential serious problems?
Given the organs involved, the big risks are things like permanent brain damage, liver failure, acute respiratory failure, and brain herniation, where the swelling gets so bad the brain tissue shifts, which is often fatal.
And other systems affected?
Cardiovascular collapse,
Yeah.
aspiration pneumonia from the vomiting, GI bleeding, pancreatitis, acute kidney injury, sepsis.
Yeah.
Basically, multi-organ failure can occur, and ultimately, death is a significant risk in severe cases. It really underscored the potential severity of this condition.
It really does. Okay, so we've covered the definition, that crucial virus-aspirin link, the mitochondrial theory, the presentation, especially the infant differences, the huge differential list, staging, investigations, the supportive management, prognosis factors like ammonia, and the potential complications. That feels like the core stuff from these notes.
Yeah, that hits all the key high-yield points. Understanding those aspects really gives you a solid foundation on Reye syndrome.
Which leaves us with our final thought for you, the listener. Given how rare Reye syndrome is now, thanks to those public health wins, why is it still so important for healthcare professionals, especially if you're studying for exams like the MSRA, to know all these details?
I think it's because, while you might not see Reye's itself very often, the things that looks like that differential diagnosis list are common and serious. You have to know Reye's well enough, including its variations, to keep it in mind when you see a child with encephalopathy and liver dysfunction, because missing it, however rare, can have devastating consequences. So, yeah, vigilance is still key.
Absolutely. Knowing the patterns, the mimics, the red flags, still vital. Well, thank you for joining us on this deep dive into Reye syndrome.
Hope this breakdown helps you feel more confident about this topic, whether it's for revision or just expanding your knowledge.
And remember, if you are revising for the MSRA, you can find loads more resources over at passthemsra.com and also at freemsra.com.
Until next time, keep learning.